Good afternoon and welcome to our weekly update from the Department of Behavioral Health. It's a pleasure to be with you today. Next slide, Brian. This June is Pride Month and we want to... Good afternoon and welcome to our weekly update from the Department of Behavioral Health. It's a pleasure to be with you today. Sorry. We're trying to improve our experience here, and so we have two laptops so I can also see the chat later in our question and answer period of time. And we didn't turn down the volume, so I could hear myself in a delayed way. Anyhow, June is Pride Month. And so we'll be talking a little bit throughout the month about what does Pride Month mean. And today I will point out my new flag pin, my rainbow flag pin that just arrived at my house yesterday. For those of you who don't know about the rainbow flag and what it means to the LGBTQ plus community, it was devised in 1978 by an artist by the name of Gilbert Baker. And it was actually a rainbow flag in fabric at the time. The colors have changed over time, interestingly enough, because for periods of time, certain colors of the material he was using were not available. But my flag has all of the 7 original colors. The color that kind of dropped off the flag is pink. But really, the different colors of the flag are really meant to represent the diversity of the community and are used as a symbol for both individuals who are part of the community as well as those of us who are allies of the community to show and express our support. And so you'll be seeing me from now on. I had a flag pin in the past and then I lost it. And I kept looking for one, and we've ordered some for the department as well. But I found this one on Etsy, and I love it. So that's my flag pin. Okay, next up. Some of you, hopefully all of you, have gotten emails from me over the past couple days acknowledging what our entire country and world is experiencing right now related to racial injustice and racial inequities. And today I sent out an article around microaggressions. And so the slide that you're seeing here just gives you a couple of examples. The article I sent has a lot more examples about what are microaggressions. One with the African-American gentleman says, "You are so articulate," and his sign says, "It's unusual for someone of your race to be intelligent." That's an example of a microaggression. And then asking someone of a different culture or race, where were you born, implies that you're not an American, you're a foreigner. And these are just small examples of microaggressions. Many are racial. There's also microaggressions against people of the LGBTQ plus community and other marginalized communities that we could use as examples. Our department, myself personally, is committed to taking this moment in time and not letting it go, but being part of a larger effort across our community. We've got to change our culture. And so you will see myself, along with our diversity services coordinator, Tiffany White, really beginning to add to this conversation, add to our knowledge. As a middle-aged white woman, it is my responsibility to educate myself about my own biases and to learn about those biases in a way that allows me to change my behavior in our world. And so we'll be providing all of you with the opportunity to educate yourself and to learn how we can better eliminate this type of situation where racism exists and is alive and well in our community. I've had the opportunity through some work I've done in our community, work I was invited to participate in, really learned about changes in how racism is propagated and demonstrated. And some of the very old-fashioned or covert means of racism you don't see as much today, but the very subtle, the microaggressions and subtle signs of racism, allow it to be propagated when we still want to say it's not here. I'm not a racist. I wouldn't say racist things, and yet I might say something unintentionally that has the impact to someone that is racist. And so we've got to do that work in ourselves to change the culture. The culture isn't going to change unless we change. And so each of us has to take the responsibility on our own to address that. My own family is struggling with this right now. We're having some very, very difficult and painful discussion about old ways of how, for instance, my parents were raised, and how that might manifest itself in ways that would be offensive to others. And so it's tough work, it's painful work. I know at times when I've had to examine my own biases, it hurts to think that I've done something that could hurt someone else. And sometimes when it hurts us, it makes us lash out at other people. It makes us deny that because we don't want to face ourselves and what we might have caused. We've got to get past that. We have to be willing to have uncomfortable conversations, oftentimes with ourselves and our family members and our friends. I recommend you don't have those conversations on social media. It works a lot better to have them in person. I know this from experience, but we're going to have these conversations. And so from me and from our department, we're going to make it part of our routine that we have these conversations. We're going to make it part of our routine that we get this out in the open. And it might get a little uncomfortable, but that's okay. When it gets uncomfortable, we'll know we're doing the right thing. So while this was my COVID update, I thought I would take the opportunity to further the efforts that we really want to accomplish with regard to racial inequities. Racism impacts all of us. It impacts the health of our community, the mental health of our community. It impacts poverty and housing and all kinds of aspects of our community and our economy even. And so we have to work together to change this. All right, off my soapbox there and on to COVID. So as you all are well aware, we continue to see COVID cases go up. We expect this. This is going to continue. We have about 6.4 million across the world, 382,000 deaths across the world through today. In the United States, over 1.8 million cases and over 106,000 deaths. And then in California, over the last week, we've increased by about 20,000 cases and about 500 deaths. So both of those things continue. As we've begun to open up, we talked about this last week, but as we've begun to open up, we probably really won't know the impact of that for several weeks. It can take 2 weeks to 10 weeks for someone who's been exposed to COVID to go through the process of having COVID, possibly get hospitalized, and possibly die. And so we really won't know the impact for several weeks of what the reopening is doing, and particularly as we just went through a holiday weekend where there was a lot of activity. And so it's something we'll have to watch very closely. In Fresno County, we've increased our number of cases from 1,535 last week to 1,914 this week. That's about a 379 number increase, and we've had 11 additional deaths from 26 to 37. If you'll recall, I'll just remind you again that oftentimes deaths are reported in arrears or after the fact, and so this is something, again, that we have to watch very, very closely. All right, so why do we have to use a mask? We've talked every single week about we're gonna have to learn to live with COVID. And I have to say there's been many discussions around my dinner table about this issue, in particular that it seems like we're all just so ready to get back to normal. And I know I'm ready to get back to normal. I will mention I did finally get my hair done this week. So getting back to normal is something we're all interested in doing, but we have to still remember that COVID hasn't went away. And protecting ourselves from COVID is just as important today as it was 10 weeks ago. And so I'm sharing with you a graphic that was created through community medical centers that they have available. And it really talks about how quickly can germs spread. And so on this, you can see if you're just breathing, a single breath releases 50 to 5,000 droplets. And those are just droplets of moisture. Most of these are considered low velocity. They go to the ground quickly. But there are even fewer droplets when you're breathing through your nose. So breathing does release some droplets, and those droplets could contain virus. But breathing is not as much as a cough. So a single cough releases about 3,000 droplets, and they can travel up to 50 miles an hour. Most of them are large, and the larger the droplet are, the quicker they fall. But many can stay in the air and can travel across a room in just a few seconds, unless you reach a barrier, like a wall or a partition. And then a single sneeze releases about 30,000 droplets, with droplets traveling at up to 200 miles an hour. Who knew? And most of those droplets are a little smaller, so the droplets released with a cough are bigger, the droplets released with a sneeze are smaller, and can easily travel across the room, again, until they reach a barrier. And so the next slide will kind of talk to you about why is that important. So if someone is a COVID carrier, and a COVID carrier, remember, isn't necessarily someone who knows they have COVID. So we know that there is asymptomatic COVID out and about in the community. So it could be you or I, and we'll either never have symptoms of COVID that we recognize, and we'll have COVID and recover from COVID without ever knowing we have it. Or we might have a period of time where we are symptomatic or asymptomatic of COVID, where we're expelling virus, but we don't know we have COVID. And so we're just out and about. We haven't isolated ourselves. So the top of this talks about if you're a COVID carrier without a mask and you're next to a healthy person without a mask as well, and this is where you're within the 6 feet. You're very high risk at potentially exposing that person to COVID. If you're a COVID carrier without a mask and the healthy person has a mask, you're at moderate risk. So you're the COVID carrier, you're spewing out virus, and the healthy person has some protection by having a mask on themselves. If you're a COVID carrier with a mask and the healthy person does not have a mask, you're considered low risk. So the COVID carrier having a mask is more important than the healthy person having a mask. And remember, this is what we've talked about. This is what they learned as more information came in, is that if the person who's carrying COVID has the mask on, they can be more protecting of the people that don't have the mask. If the person carrying COVID has a mask and the other healthy person has a mask, even when you're not social distancing, even when you're passing each other in the hallway, even when you're standing next to each other at the grocery store, it's extremely low risk. And then if you're within 6 feet, and you both are outside of the 6 feet, so you've maintained the physical distancing and you both have a mask on, there's really little to no risk of exposure. So if everyone would wear masks, even though it's uncomfortable, even though people sometimes wear them wrong, then we could all be more protected. So this is why it's important, as we all want to return to normal and we all want to be safe. At the same time, if we're wearing a mask, that's how it will help us. All right, on to what we're doing. We now have a county template. The county has issued a template that each department can use as we develop our plan for return to work. Part of that is doing an analysis of the hazards or risks associated with that. So things like where would people congregate and what measures can we put into place to mitigate risk. We will make sure that that template is available for all of you to review. So that's just looking at what are the things we're looking at, how will we have to fill that out. And once it's completed, we'll make sure it's available as well. So in terms of our current plan for telehealth, it will continue through June 30th at a minimum. So right now we're not planning to bring clinical staff back any earlier than the beginning of July, and then we'll be looking into that. Some non-clinical areas may begin a gradual return to work towards the middle of this month, but we really need to have that plan in place and both get approval at the county level as well as reassure all of you that we have a safe plan in place. We will, of course, continue our daily health screening of all staff and visitors and clients at all of our facilities. And we now have an adequate supply of PPE. We've done an assessment, particularly in our clinical areas, to know based on the client volume and the types of procedures that are done and what the recommended protective equipment is for each situation, how much of the protective equipment we need to have an adequate supply for at least 60 days. So our goal is to have at least a 2-month supply of protective equipment and then a strategy for resupplying that protective equipment as it gets utilized so that we are always having an adequate supply on hand. We all know at the beginning of the pandemic, we went through a situation where there simply wasn't access to supplies of PPE, and we don't want to get in that situation again. So we're ordering supplies so that we have an adequate supply at all times. Not knowing what the supply chain will do, we think if we have at least a 2-month supply, we'll be in a good situation. All right. Before I open it up to questions, I also want to mention that there was a question last week related to when we would be recruiting for unlicensed clinicians. I did want to answer that question, and briefly what I'll tell you is that some work that was being done prior to the pandemic was around updating the job specifications for the unlicensed clinician job, and in particular adding the professional clinical counseling as a category that qualified to be an unlicensed and a licensed clinician in the county. It's our belief that by adding this category, we can increase the number of eligible candidates for these positions. And because they're such critical positions in the county, we want to make sure that we have access to all of the job the licensure categories. And so that work is being done, and once it's finalized, then we'll bring that into the queue of priorities for recruitment. We have gotten approval. We have lots of openings right now, and we are recruiting for open positions actively. But that's the delay with the licensed and unlicensed clinician category, is getting that job specification updated. And so we're working on that and hope to have that done as quickly as possible, so that as we move forward and know that there are need for our services, that we can recruit across a broad spectrum of licensures. Okay, I'm going to look over here and see if I see any questions. Am I looking at it right, Brian? Do you see any?
I don't see any.
Okay. We have it set up and there's no questions now. I will give it another minute or two and see if any questions arise. If not, I will let you know that I do plan on continuing some version of this video meeting that I'm having with you weekly, at least for the next several weeks. We may go to only reserving half an hour, just so that we're not having you reserve more time than you need. And as usual, we'll make it available afterwards as a recording. I have gotten feedback from people that they appreciate having this update, and it may be the tool that we need to keep our communication going, as well as the email updates that we send out periodically. There is a question here about will there be clinical reassignments? I don't have an answer to that right now, but I will for sure have an answer to that either by next week, or we'll send something out about that. And I'll let you know the answer to that question. The masks that we are getting tomorrow are those supposed to be worn when we're not at our desks. Each of you will be getting, if you haven't already, 2 cloth masks. They're a blue color, and those are for you to wear in any situation where you have contact with someone within that 6 feet distance. As we develop that return to work plan, right now we have, in our clinical areas, you're required to wear a mask, so there's really no question there. But in our non-clinical areas, we're not right now requiring people to wear a mask because we have so few people in the building. For instance, we try and wear masks when we're coming and going. Frankly, we're not doing it as good as we should, but there's not as many people in the building. So knowing that we are going to get to a time when it's going to be unavoidable to interact with people in the building, remember, the highest risk times are when you're within 6 feet for more than 15 minutes. But in my prior example where I showed you what the risks are, we want to make sure that we give you direction on when it's appropriate to wear that mask. So we don't anticipate having people sitting at their desk all day wearing a mask. We anticipate having workstations set up that you're not within 6 feet of people, that there's physical barriers like walls and partitions between you and other people, so that if you did cough while you were sitting there or they coughed, you're not exposed to that. But we do anticipate recommending, for instance, that you would wear your mask in and out of the building where you might come into contact with other people during the arrival or exit from work or lunchtime where more people might be in the area at the same time. Likely we'll recommend that you wear the mask when you're in common areas like hallways, bathrooms, break rooms. There'll likely be some rules around break rooms, around how many people can be in there, how long, etc. Again, we're trying to protect you and we're trying to create a work environment that's safe for you. So we will be giving you very specific guidance, particularly as people return to work. You should always feel comfortable wearing the mask whenever you feel like you need to wear the mask. That could be at a higher level than what we're recommending. But once we put our return to work guidelines in place, as we anticipate more people being in the building, it will be the expectation that you'll follow the guidelines and wear the masks as we recommend. Okay, I got a question about my Pride pin. I got the Pride pin from Etsy, and if you go on Etsy and you say Pride lapel pin, then a Pride flag lapel pin, rainbow flag lapel pin, you'll find lots of options. I chose this one because it was the original 7 colors, and I just liked that. We have a question about, is the budget going to be impacted from the shutdown? A couple of weeks ago, I think I shared what the governor's May revised budget anticipates. And right now, the governor's budget anticipates a reduction in our realignment revenue, sales tax, and vehicle license fees. There is active advocacy going on at the state level to restore in the final budget as much of that realignment as possible, recognizing that the people we serve are a vulnerable population and the need for our services is anticipated to increase. It's anticipated to increase because as people have lost job and faced economic impact, we think more people will qualify for Medi-Cal. And it's also anticipated to increase because all of the after effects of the pandemic and now the racial injustice and the protests that we've all experienced, we anticipate will heighten the need for our services amongst individuals. And so we really believe it's important to preserve as much as possible the limited resources we have so that we can continue to provide services. So stay tuned on that. One of the things you should anticipate in our budget is that there'll be very few positions that are new that we'll add in the budget. We'll be watching very closely and trying to completely fill the positions we have, and then making sure that we're being judicious with what we have. Does productivity impact when staff are able to come back after June 30th? One of the things, I'm not exactly sure what that particular question means, but I will tell you that Productivity is always going to be important. We want to create an environment where our staff is able to be productive. Even in the telehealth and telework environment, that becomes ever more critically important. I think we're all a bit energized and intrigued about the opportunity for telework and telehealth, and so it's going to be really a very careful, methodical review we do about what type of work can be efficiently and effectively done in a telework capacity, both clinical and non-clinical work. And I've shared this previously, but I'll reiterate. We have to be able to have a metric to be able to measure whether or not the work that's being done is efficient and effective. So what I mean by that is, can you competently carry out your work? You have the tools you need. You're able to complete projects, process tasks that you have to do effectively. Able to communicate with people and do your work. And then the efficiency part is, if you were able to do 10 of something when you were in your office, can you still do 10 or maybe even more at home? Or if you do less, how much less? Obviously, if we find that people are very inefficient at home for whatever reason, we're not going to be able to allow people to continue working from home. That just won't work. Then the burden is on us to create safe work environments. But where we are able to support efficient, effective work happening in a telework situation, we're certainly willing to explore that. On the telehealth side, there's two aspects to that. One, is it meeting our clients' needs to do telehealth? Is their satisfaction with the telehealth work environment adequate? And then, is it effective for them? Are they getting what they need out of it to maintain their health and their well-being by receiving services either through video or telephone? And when that isn't happening, is there the capacity within our system to see them in an in-person environment? So we have to have a balance there. We will never, ever, ever, let me make that clear, we will never, ever, ever be in a situation where all of our services are done through telehealth or telephone. Even during the pandemic, we were not in that situation. We have still had urgent services and emergent services, and some of our medical services continued somewhat, certainly in a protected environment, but somewhat unabated during that period of time. And certainly our crisis stabilization units, our inpatient units, our crisis residential, all continued. And so we are not converting to be a telehealth or telephone environment. And so we have to carefully balance that. Some of that's going to make it difficult as we move forward, as some people are going to say, well, why does that position get to do telework and I have to come in, or vice versa? And you're just going to have to work with us. We're in an emergency situation now. As we move forward, we'll look carefully at what we can continue long term. Obviously, that will involve some negotiation that goes on, and we'll have to determine whether or not we can come to a resolution on any of those issues, and whether that would support continued telework. So right now, we're still in a situation where we can continue it as needed, but as we move forward, we'll be looking at that very carefully. All right, let's see. With regards to keeping a safe distance from each other and thinking about our break room space, could we look at bringing back our own fridges or microwaves? Probably not, because there are electrical hazards associated with that. I would love to have those in my office too. In my last job, I did, and I appreciated having that little fridge in my office. But for us, that's going to create some issues that would be very difficult to overcome. So in terms of break rooms, we're going to work really hard to come up with strategies for how we can safely have our break rooms utilized. And right now, I don't have any more questions. As usual, if any questions arise in between these sessions, please reach out to me personally. I think those of you who have will find that I'm responsive, and I will work hard to get answers to your questions, especially those that I don't have the answer to. And as always, we remain committed to being here for the people we serve and the people that are are serving. And so thank you very much, and we will see you next week.